Hello, everyone, and welcome to the webinar. A few housekeeping rules to start. We will begin and end on time. We will save all questions until the end of the presentation. All attendees have been placed on mute. Please type your questions into the chat box at the bottom right of your screen. Without further delay, I will turn it over to Skip Ashmore, Chief Medical Officer with TeleTracking. Skip, thank you for joining us today.
Thank you, Ashley, and welcome everyone. And I wish I was a medical officer. I'm actually the marketing officer, but on behalf of TeleTracking, I want to thank everyone for taking time out of your busy day to join us for what I expect to be a wonderful webinar entitled Improving Patient Throughput with Very Important Discharge Appointments, also known as VIDA. We have two outstanding speakers today from the Torrance Memorial Medical Center. They are Shanna.Hall. She is the Vice President of Nursing and is responsible for daily operations and oversight of 10 critical care and medical surgical departments, including the ED, telemetry, and dialysis, with over 800 employees. And then we also have Daniel Palma. He is the Director of Medical Surgical Services. He's been a registered nurse for 19 years. And he's dedicated to streamlining processes that directly impact not only patient safety and throughput, but also length of stay, which you'll see is very evident with the VIDA program. So without any further ado, I'd like to turn it over to Shanna and Daniel.
Good morning, everyone. It's a pleasure to be with you. I appreciate the opportunity to share our story. It's really relevant with all the things that we're facing as a healthcare system throughout the country. And I think that in the end, you're going to have a few tips that will hopefully help you. Looking forward to taking some time and answering questions at the end. And I think it's just a privilege. So I know Daniel and I have a lot to share. Torrance Memorial is a license for 610 beds. Like many hospitals, we don't operate at that capacity. Some of those are not staffed beds, but that is what is on our license. In 2018, we had the honor of affiliating with Cedars Sinai Medical System to create a health system. And at this time, we've had Cedars, Torrance Memorial, Marina Del Rey, and now new is Huntington Memorial. So we're very appreciative to have like-minded affiliate hospitals. We have many things to share, like a lot of you on this slide that we're quite proud of. We are a 3-time Magnet Hospital, recognized by U.S. News and World Report. We have Beacon ICUs, Beacon award-winning PCUs, award-winning med-surges, and many centers of excellence. We have a comprehensive stroke program. We run a bariatric service, open heart, a level 3 NICU, and we are a busy community hospital, but also in a really competitive market of LA County. Our mission is to provide patient-centered care, looking to be collaborative in our community, but also that we certainly want to retain our market share and to build on our services and delivering the best care possible to the residents of South Bay. So what does all this mean? Well, it means that we are quite busy. There's a lot of pressure, and we have many competing priorities. For today, what we hope that you come away from this presentation is that you learn about our strategy and what we did to really reignite our patient flow efforts. Also, how we utilize and embrace lean methods in order to achieve our goals, reduce inefficiencies, and to improve our length of stay, and how to maybe roll something out that makes you a little bit queasy on how are we going to do this, because we've talked about it for a long time, but we really haven't pulled the trigger in a sustaining way. We're pleased to be partners with TeleTracking. They have been incredible. Honestly, I'm not sure we would have had the confidence and know where to begin if we didn't have the great support from the TeleTracking team. We have a wonderful sales rep who really cheers us on and connects with us on a frequent basis. Patrick, I'm going to give you a shout out. He's been amazing, and Aya as well. Really talented, great people. And their Vice President Tammy has just been tremendous in helping us solve issues. So these are our 2019 stats. Community hospital, we're a large hospital. We have a very active, busy emergency department, 88,000 visits in 2019. And I have a 54 treatment space emergency department. So for all of you that are in hospital operations or deal with patient flow, you're going to definitely shudder when you see that we have that limited capacity with seeing so many patients. We, have done many efforts to maximize our flow and our treatment spaces. We did the pod system back in 2010, and at 2011, we reworked some things. We had an on and off start with patient flow over the years, and was really feeling growing pains and a lot of boarding hours and diversion when we started this journey. But we're quite busy, and 21% of our admissions come from our emergency department. So really kind of how we funnel in a lot of cases. When we started, I think this is a powerful, it was a wake-up call to us as we evaluated where we were at with our patient flow. We were really at stage 2. We were quite reactive. I mean, raise your hand if that's your hospital, right? That's real. Something occurs, then there's a reaction, but it's not sustainable, or it's very person dependent. When you have key people there, everything's going well, but does it really work like that on a weekend? Or when you have per diems or a holiday? And how are we able to be more proactive? So we took a hard look in the mirror and we realized it's a leadership failure. And that's what it is when you are operating in the state of always being reactive. And I had to acknowledge that and own that. And that is where we began to do some of this hard work in 2017. I was new in my position as a vice president. The emergency department had started to report to me, although I had had all these other areas, and it just didn't feel great. We were always in a state of boarding. It was a lot of pressure on the inpatient departments. The emergency department didn't feel supported, and we knew we had to really peel this back and do some of the tough work, which really meant culture change. And how were we going to go about this? We decided to take a look at our data, and what we realized was we needed to focus on getting the right patients in the right bed at the right time and not be moving and shuffling people around, because that's very inefficient. That was causing continued backups. We needed to target the units and what time the bed could go to that unit, as well as ready to move. We had a lot of gaming happening and a lot of batching. Emergency departments say they don't batch. Inpatient units know they batch. So we had to really break that down and acknowledge that this really is occurring, but why is it occurring, and unpacking that. So we decided to start a restart. That's what I call the reigniting of a patient flow steering committee. And I went to the CEO. We have a wonderful CEO, and asked for support to restart this committee. And a lot of people were like, well, sure, if you want to lead this committee. I mean, we've done this before and we're just not getting very far, but we just couldn't afford to not do it any longer. So we restarted the committee with what I felt like was key stakeholders. We have representation from the hospitalist team, the supervisors. We have representation from key inpatient units, as well as the emergency department and emergency department physicians, because they really had a lot of passion for the topic. But also a big partner was our director of our operational improvements. He has been so supportive of helping me get data ready, keeping things on task, and also really asking that we utilize the lean principles that we've been sharing for many, many years, and really putting it into action. We established 3 goals. And we felt like these 3 goals, with the guidance of our teletracking support, would get us where we were going. And they were goals that we could really unpack the complicated processes behind each goal, because we had bad habits, we had myths, we had all of this historical, way that we always do it, or we've tried this before and it didn't work. A lot of hospitals have these goals, but it doesn't really work. So we established these 3 goals, having the patient ready to move, to improve, ready to move to bed assigned within 15 minutes, 50% of the time, to improve the bed cleaning response time. I didn't want to shorten how long it took to clean a room, because we did a lot of practice and look at the evidence about how long it takes to clean our rooms the way we feel like they should be cleaned. So we didn't want to shorten that. But the time it takes to get to that clean room is what we thought we could impact. And there was definitely some low-hanging fruit there that we thought that would make a difference. So we wanted them to get there within 30 minutes, at least 50% of the time. The next goal was to have patients discharged by 11. This started out with it being a percentage, I'll tell you, and we reworked that goal because the percentage did not resonate with our staff. It was too lofty, it was hard for them to figure out, so we changed that to really reflecting in a whole number. So we said 180 patients by 11 a.m. And when we started out, we were doing about 78 a month. So that was a pretty big goal. And we knew it was going to be a culture change. So at this time, I requested and told a few key leaders of these areas to work together, and they led Kaizens based on each of the goals. And we did this starting in May of 2017. And really pushed that we were having these processes starting to change and doing rapid PDCA cycles by late summer and into the fall and winter time of 2017 going into 2018. And that's where Mr. Palma Daniel comes into play, because he was the director that I felt like had great experience with change management and taking on tough projects, and being very collaborative and building processes. And I will let Daniel share this amazing way that we have approached getting people out by 11.
Thank you, Shanna. Appreciate that. Yeah, I was the lucky one to be voluntold to take on the 3rd goal that everybody saw in the last slide. So when I looked at this particular goal, looking at the data, we were discharging only 4% which equals about 60 to 70 patients per month before 11 o'clock. There was just no efforts. Even though we said we are going to discharge patients before 11, there was no standardized process around doing that. And so where we're seeing the majority of our patients were being discharged between 3, 4, 5 o'clock. And then this was just creating a backlog, and boarders were in the emergency room. We were getting complaints from patients, administration. Nurses were having to go into the emergency room to take care of these patients, and which created dissatisfaction on their end as well. Physicians were calling me, why is my patient in the emergency room? So it just created a lot of dissatisfaction, and we knew we had some work to do. So the biggest problem was, getting those patients from the 4 or 5 o'clock moving up into before 11 o'clock. So the next slide, I have a little video that I'm going to show basically some of the lack of standardization in our hospital.
Everyone that's in this hospital, think about that they're having the worst day of their lives. And when you don't put emphasis on, emptying out of bed so someone can occupy it, then, you know, the workflow just kind of stays stagnant.
And so when this backup occurs in the ER and the PACU and everywhere else in the hospital, in ICU, PCU, and med-surg, we have no room for flow for patients that are coming in.
Meanwhile, that patient upstairs that was occupying the bed could be going home, but we didn't have everything in place for that patient to go home.
Because you may need insurance authorization to get that accomplished. It may not be safe for someone to go home without the equipment that they need.
But that would mean a doctor would have to visit that day, they would get assessed, and then they're more than likely to go home at the very end of the day.
It's a domino effect through the whole hospital. It starts on the floor, and then it kind of trickles all the way down through everybody from the nurses to the cleaning staff to the emergency room to the OR to the PACU. Everybody's affected by this.
So the families are stressed out, the patients are upset, sometimes even the surgeons, the doctors are upset, their patients are waiting long times to get a bed.
So just planning ahead and just looking at how you move patients appropriately and safely around in the hospital, it has helped tremendously.
So as we got our team together, you know, we thought to ourselves, you know, if resorts and hospitals can have a really good solid process of making sure you're checking out at a certain time, people checking in at a certain time, you know, why can't a hospital, right, that are saving lives have somewhat of a similar process, you know, between discharging our patients? So that's a good reflection of what came to our mind as well. So as our team got together, you know, it was a multidisciplinary team between physicians, physical therapists, case management, staff nurses. We all kind of like in a boardroom, you know, we're like, how do we build this out? How do we create the best practice? So we created a standard operating procedure, SOP, and we wanted to color code each one of them based on the role. For example, the charge nurse, lead nurse has a specific role of the VIDA. That was their color orange, right? And so, because we knew that getting the key stakeholders involved and buy-in, we don't want it to appear as overwhelming. And so in the SOP, you know, we have very simple criteria we've established. The nurses at the bedside, you know, and the charge nurses of the units, they take full reign of this SOP. There's criteria illustrated, and if it's followed to the T, it's been proven to be successful. So as we put this into play, the next video will show a little feedback from the staff.
Patient flow is really pre-planning the discharge, and the time is important. So it's supposed to be before 11 in the morning.
So the team got together and we started working on a plan for this, and it involved the entire care team. So step one was developing an SOP. The SOP was great. It had even a color scheme, so you knew exactly how your role related to the SOP. And then we started educating the inpatient staff. There had to be a lot of buy-in from everybody involved to even set the project in motion, and then to roll it out, to have everybody, you know, on board. We always pick at least 2 VIDAs the night before, just in case that one of the VIDAs falls through. We are able to work on getting the other patient out so that we can always assure that at least one patient is leaving before 11 o'clock.
That way the night shift knows, then the day shift knows the following day who that particular patient is that's supposed to go home early. As soon as the doctors start rounding, the case managers start rounding, the social workers, we disseminate that information to them as quickly as possible so that they know we're trying to get this patient out of here by 11.
When you get there in the morning and everything really has been done and everything is all set in motion, you know, we were able to discharge this patient on time, everything is set and you feel good about it and everybody's happy.
We had something called huddle or discharge rounds. It's different per unit. What they call it, but in this meeting are basically what the patient needs to go home, what their discharge needs are. And at that point in time, we can identify from day one what any obstacles will be for their discharge.
We have a TeleTracking board where we'll assign a patient whether or not they're, if they're a VIDA for the following morning, so that anyone who is involved in that patient care, they can easily see that there's an icon there and the patient is assigned as a VIDA.
Knowing which rooms, for example, they're going to come out. Us as housekeepers, we can go ahead and take care of those rooms in a timely manner because we still have to provide them a daily cleaning in those rooms. That helps me out when they're gonna leave early, so they can go ahead and take care of that room.
By having these beds ready, then we're ready for those 5 emergency cases or 10 or whatever it is. Like today is a good example of that. We have a lot of emergencies and a lot of intensive care patients that need a higher level. So we have to get those beds cleaned and move patients around.
So this shows staff with really, I think, in a state of readiness to accept this culture. But Daniel and I and all of our leaders, we spent months sharing our story and the connectiveness about this is not an emergency department problem or issue. It's about all of our patients. So we continue to talk about, we have a commitment for patient-centered care and what is our mission, and that getting our patients connected to the right care at the right time really became our mantra. And that is what we talked about, because of course, when you start to introduce something new, nurses think, is this another flavor of the day? And are we going to just be able to wait you out? Or are we going to have a start and then stop and we can fade away? And it really took a lot of tenacity and determination. And anybody that knows me knows that I have both of those things, and my team really embraces it and leans into that. So we're not stopping and we're not giving up, and we're going to continue to do this, and we're going to do it over and over again until we get it right. But for the nurses, it was also like, is this another thing we have to do? But what we tried to really explain to them is you're already doing it. It's just that it's fragmented and chaotic. So if we did it in an organized manner, it's going to take all that chaos, wasted steps and energy, and the burden from being on one shift or in one area, and it spreads it out so that we're much more efficient. And in the end, the patient has a really good experience, and we're meeting all these flow needs. And when we were able to get them to see that and feel that during the beginning of the PDCAs, they really became a spark to take it forward as well.
And like as we created the SOP, as everybody knows, when you create an awesome, plan, it's a very different scenario when you want to implement this plan. And so that was one of the more difficult things, was to get this into motion. We had 10 units that we wanted to roll this out in. How we first did this was we showcased the SOP to all the units. We had one specific unit that I call my champion unit. And we pre-selected, unit champions to really, we kind of briefed them, we trained them on the SOP, got them the little cheerleaders, and kind of created it more of like, this is not going to be more work like Shanna mentioned earlier. This is something that you're already doing. We did a VIU, we got lots of communication out to the doctors. One thing that I did not do on the first initial unit was I didn't do a lot of showcasing to the physicians, and as I learned that as I was beginning to roll this out to the rest of the units, was I created SBAR format communication to all the physicians and the surgeons, and this is what we're doing. I attended around, did a lot of one-on-ones, and the most important thing is supporting the staff for this change, and making sure that they don't have a misperception of added work. That this is actually good, and this is for our patients. We want our patients to get the care that much faster, and so having a bit of a process around discharging our patients early has really saved us a lot. And so some of our early struggles, we did have a slow start, like I said, one unit, and then of course, Shanna, her being tenacious, she wanted all 10 units to go up, within a month. And so as I began to, build up the units, I needed to seek help. I reached out to the other PCU director, Sean. He's a great guy, and he really helped me roll out the VIDA within all the areas. Like I said, doctor awareness, case managers, unit engagement, but more importantly, it was the data transparency. The staff wanted to know, how were they doing? How were they performing? Is it successful? What are the patients saying? So this is some initial thoughts from staff when we rolled this out.
So the initial reaction to the VIDA process was, I think, a little bit of concern and pushback from, again, from doctors and nurses, because it does seem like added work in the beginning.
It took a little while for us to actually get used to it, but they're pretty proactive with it now, I would say. Yes, at first it was very holding back, negative, but they started being more involved and say, hey, if you need me, I already finished this one, so in case you get a discharge early, I'm open to help.
So anytime you develop a new process, it seems like it leaps in the air, and then we kind of start to coast. So we started doing a celebration process.
So whenever the nurses come to me and tell me that they have a patient that's a VIDA, they're usually very positive and motivated. Let's get this patient out first. So we have little competitions between units. So if somebody gets more VIDAs out, then they'll get a prize or they'll get food, which nurses always like food. So it's always a motivation.
On our floor, personally, we have VIDA champion doctors. We've given out a couple of certificates to the doctors that come every morning and say, let me give you your VIDAs for the day. So some doctors are really on board with it. They know that if they get their patients out, their next patients coming in haven't been that much quicker.
Before, we were seeing a lot of admits right at change of shift, terrible time to get a patient. And so we really want to get those patients from the emergency room up early into a clean room.
The length of stay has drastically reduced. We're not operating in silos anymore. We're actually looking at things globally, and our patients are much happier.
So, I mean, for VIDA, it's great for patient flow because now my patient flow is flowing.
I do think, like Daniel said, having a tag team when you're doing this type of rollout really helped, because he was rolling out a new unit or 2 units every 2 weeks. And then the other director was keeping the units that had been rolled out on pace and with accountability and keeping them encouraged. And I was ordering a lot of food. So Daniel had great ideas. I was trying to support them with the celebrations. And whenever we would see a little bit of a lag or an opportunity to do a contest, we made sure VIDA was a piece of that contest, so that we could continue to keep that energy going and really solidify in our culture.
Yeah, here's just a snapshot of all the celebrations and the competitions between each department. And it's a branding, it's a culture that you have to instill into the hospital, that this is what we're doing. And staff, they just love competitions. They love that competition between each unit. So they did enjoy this part. So when it comes to the data, you know, we felt that it was really important that we showcase their performance in real time as much as possible. We would send out weekly updates. We would post this information in their huddle boards, and then they can see how they're performing from the week prior. And like anybody else, is very competitive. If you're not hitting your mark, you know, it's everybody can see how everybody's performing, and they can see, like, guess what? We got to step up, you guys. We have to do better than 7 West or whatnot. So we thought data was super important. We also send out what we call halftime reports. On the left side of the screen is our halftime dashboard, and I let them know how they're performing halfway through the month. And as you can see, most of them are hitting their goals, but the numbers are just beginning to double up, you know, from the completed dashboard on the right side. We want them to reflect on how they're doing and just make sure that they keep this, you know, as a priority. So just like any other process, you know, and implementation comes accountability. You know, what do we do when a unit is missing the mark or struggling with the mark? On the left side is what we call our VIDA verification. And if a unit just misses the mark for the month prior, what they are required to do is a VIDA verification. And what they're doing is they're actually validating the SOP and the process around the discharge before 11. This is going to help us determine what area in the process are they struggling with. Is it equipment that's not available? Is it the ride is not here? Is it the text didn't go out to the care team? And that helps us really determine where to focus our efforts at. On the right side, we recently converted this over into our new digital platform. It's the same questions, but it's a lot easier for the nurses to complete. And I will say 95% of the time, if a department misses the mark, when they complete this verification, the next month they're hitting their goal, which is really important. And that's one thing that we didn't do initially was we did not implement the accountability piece, which we really felt this is a crucial part in being successful.
We also, a couple things that are in the SOP that you can't really tell, but is that the care team, meaning the case manager, the physician, the respiratory therapist, PT, they all receive a text. And the text is, congratulations, your patient, it says the patient's information. This is on our secure texting system, is designated a VIDA for tomorrow, or they get it in the morning that says is designated the VIDA for today. Planned discharge time, and the time is put there. So everybody knows what their role is, if they're getting the day before or they're getting the morning, what they're supposed to be doing with that patient and how to prioritize that patient. On the patient's whiteboard, again, it's put on there that they are a VIDA patient, and we make it very special. We're congratulations, you are, you've accomplished your goals, and you are a very special patient with a very important discharge time. So it's something that they're proud and excited about. And our own employees who have family members that are patients in the hospital, they're always quick to say, oh, my husband's going to be a VIDA today for sure. We're going to get him out of there early. So it's been really fun to see them grab onto that.
And initially, when we first implement the VIDA process, our first thoughts were, how is this going to impact patient experience, primarily around the discharge information? And I will say, at that time, Torrance was about 84 to 86% on HCAHPS. We're a 4-star CMS HCAHPS, and we did not see any difference, with our patient experience. In fact, we've seen an increase overall. Q4 21, we do see a small little drop, that we all struggle, like many hospitals across the nation related to COVID, but we're starting to regain some of our efforts.
And this was an unexpected halo effect of the efforts. We decided to monitor it because people cautioned me that I could be basically jeopardizing how well we were doing in this area. I challenged it because I felt like if it was more organized and something to celebrate, and we were having a collaborative effort, it would get better. And then, so as we have been watching and measuring that part, it did. And we continue to improve.
So on this graph right here was our first initial implementation of VIDA. And I kind of wanted to just demonstrate on this slide, when we first started, we were doing, 80 to 90 patients at that time, about 4 to 5% of our discharges before 11. The Kaizen kind of went full force in May of 2018. And then as you can see, we begin to see a significant increase in our VIDAs in percentage and the number of patients. And so now we constantly average between 240 and about maybe times even 300 VIDAs per month. So we've seen a significant change, and it's been helping a lot of our boarding hours. And this graph right here is a more recent graph. In June 2020 of last year, we were doing okay and great, considering that, we were going through COVID. And as you can see, December, January, and February was when we really impacted with the pandemic. Some staff did lose some focus, as priorities did change at that time, and we wanted to support our staff. But guess what? Come March, we're like, we got to get right back to work, you guys. So we begin to really re-emphasize the process.
And that really took leadership, mindfulness about getting people restarted, And again, you know, COVID it's a marathon, and we're in our 4th surge. We're also having the results of deferred care that is occurring right now. So we're seeing an even larger surge of non-COVID patients. So getting them refocused was important because we're counting on getting these patients with the right patient access to the beds that they need. This is a new tool that we developed, and what I wanted to do and ask Jeremiah's support, which is our Director of Operations Improvement, was how successful are we now that we're mature, we're several years in, how successful are we at picking the right patients and what's going into these patients? Surgical patients are easier to pick. They have a very predictable path. So we see our surgical floors do quite well. The patients that have really complicated, more medical patients have a harder time. However, what we said from the beginning is out of 26 patients, 2. We're just looking for 2. And out of that 2, we're hoping that 1 goes, right? So everybody can find 2 and everybody can find 1. But we did discover that some units were better at selection. So what our plan was, in using our culture and what we know about peer-to-peer teaching and supporting each other, was it's really powerful when you have a peer who's doing great at something teach you how to do it versus coming from leadership. So we've connected units who are doing really well, and we have them share their stories and how are they selecting their patients, so that other people can learn from them. And so this was something that we wanted to take a look at, and to also know, is there a difference in selection or success when they're going to a skilled or extended outpatient? Well, the extended outpatient is just something we do internally, so that doesn't matter. But and then observation versus inpatient. So just a different analysis that we took a look at, going deeper. We also wanted to evaluate how is everything that we're putting together with our patient flow affecting our emergency department. And as we were having increased emergency department census and visits, we were able to really show our diversion hours decreasing, our boarding hours decreasing, and it helped us just confirm that we're on the right path. We're doing other patient flow activities. We did start something. I know you probably are saying, are you kidding me? But we did start something last summer. It's called VITA, V-I-T-A, and it's a very important transfer and admission process. So what we were doing is we used the roadmap from the VIDA process, and we just implemented it, and maximizing a coordinated and improved time when you're transferring a patient from one unit to the other, because we were seeing a variation from taking 20 minutes from the time the bed was assigned to taking 3 hours. So we really wanted to get that more normalized and get that down to 60 minutes or less. So that's something we started working on last year in June, when we had a teeny little bit of a breather. Surprisingly, it really took, and we're doing quite well with that.
So some next steps in sustainability, you know, at the time of rollout, it took a little while to get mother baby on board, but now they're doing great and with the mother baby area. But we want to take a peek at the metrics at 2 o'clock discharges. You know, we typically sit around 35, 38% of our discharges before 2 o'clock, and really hone in and continue to support the accountability pieces, which is important. You know, we're looking for more real-time data, like daily data, to put on performance boards for the staff to view as well. You know, whenever we did we created the process, like I said, we wanted to make sure we did a branding. And this branding is the icon. And when anybody sees this icon, they automatically already know what it stands for, what it means. You know, at the end of the day, it's for patient care. You know, it's to get the right patient in the right bed at the right time. And hashtag no patient waits is what Shanna's hashtag is, which is nice. To kind of wrap it up, I had this quick little video of some feedback from some staff of kind of post rollout.
My recommendations to other hospitals that want to implement the VIDA process is number one, to be patient and to understand that there are going to be challenges in the beginning. There is going to be a period of time where people are upset or angry or just kind of not into it, but that will change, and it'll change once people realize the benefit of it.
The bottleneck of a hospital really is discharges. And that's, I think if you hone in on that, like that is going to accelerate the rest of the processes in the hospital.
If you have a capacity problem, if you have periods where you don't have enough space to deal with the volume of ill or injured people you're asked to deal with, then you have two choices. You can build more hospital beds, which is expensive and permanent and has ongoing overhead and upkeep associated with it, or you can try to use what you already have more efficiently.
It really has saved us time, hassle, money, and then patient frustration. So give it time, be patient with the process, let it kind of roll out hospital-wide like any other policy you would have, and your staff will eventually grow to love it and adopt it the way that we have.
It's been some really great feedback from our surgeons. Once we get the patients out early, that means less time that the patients are sitting in the PACU. So the quicker they get up to the floor, the earlier they can start their rehab. And if they start their rehab earlier, then they can discharge quickly.
When I round on patients, they seem really excited. They know they're a VIDA. They're talking about how they get to go home tomorrow.
You see that they have a sense of ease kind of wash over them almost.
The thing I love most about the VIDA program is seeing the patients' faces as they're rolling out good care, and we're all waving goodbye.
We just love living La Vida Loca at Torrance Memorial.
So that concludes. I do appreciate everybody's time to jump on to hear our story. We're very proud to share it with everybody.
And we're open to taking questions in the last time that we have.
Yes.
Thank you, Shanna. Thank you, Daniel. We do have some questions. Friendly reminder, a copy of the slides as well as a recording of today's webinar will be sent to all attendees within the week. If you do have additional questions, please click on the chat icon and chat them in. Our first question comes from Nini, who asks, please share VIDA icon. Was this in EHR Throughput dashboard?
The icon was drawn by one of our nurses, Jaleesa, and then she worked with Diego, who is our TeleTracking clinical applications technician, and he then uploaded it into the TeleTracking. I wish I knew how to do that, but I can definitely get a hold. If you want to give a hold of me, I can give you Diego's contact information.
And then we further use the icon on a lot of the material and the PowerPoint slides when we were going around to, because we did presentations for months and then road shows and then back again whenever there was a tweak. So, you know, it was truly a process with change management. We wanted people to truly recognize that, so that physicians all the way through to housekeeping knew what that icon meant.
Great, thank you. Our next question comes from Will, who asks, transportation either to the home or another facility is our largest barrier to discharging patients timely. Did you do anything to address this as part of your SOP?
Do you want to take this one, Daniel?
Yeah, that's a great question. You know, when we drafted the SOP initially, part of the criteria was going to be the patient had to be going home. And because so we want to get the rides situated. But what we found as we were progressing in the maturity of VIDA was we were having patients going to a SNF, and then we were having all these orders come through, and with our ambulance service that transports the patients to SNFs, they came to me asking, like, why am I getting all these orders? And I said, oh my God, you know, you guys should know what we're doing over here at Torrance. You know, we have an awesome, you know, program called VIDA. And what this is a very important discharge appointment for our patients. Is there a way that, you know, you guys can participate and help out with allocating additional transportation vans early in the morning for these patients? They were happy for the business. They were happy to do it. And so we get lots of positive feedback. So they've actually altered and changed their schedule and have allocated additional vans for the morning times for our VIDA patients.
I think that's a great example of pulling in the community partners into our initiatives, because this particular vendor had no idea, and they would accept the transport, but they had no intention of being able to do it at the time frame, which then left nursing frustrated and feeling a little bit powerless because they had an interdependent relationship with this vendor. So Daniel meeting with the vendor, and we did have a contract with the vendor, so he knew it was important to continue our viability with the relationship to helping meet those goals. But I would caution you that I think it was the right move in the beginning to have them avoid SNFs or transfers to other locations when they were selecting, because they're novice, they're new in its infancy. You want them to be successful, so maybe you take out what was a little more complicated and you have a cleaner selection so that there's some early wins. We tackled that part after we had probably, I would say, 9 months of success and stabilization, when he realized and went a little bit deeper.
Great, thank you. Our next question comes from Ginger, who asks, what effects does the time of physician rounding for discharge order affect your discharge plan by 11 a.m.? Or is the order obtained the night before? Does the doctor always see the patient on discharge in the morning, or does a nurse practitioner or physician assistant see the patient?
So it occurs both ways. I would say the majority, we get the order the day before, and typically that happens during rounds. And then, or they do, we have something that we use here called pending. So we may say that they're in VIDA for tomorrow, and that's a pending discharge, but then the physician will confirm it in the morning, and we switch it over to confirmed an order. And our orders are connected with our TeleTracking. So when the order goes in to Cerner, it automatically changes it on our TeleTracking board to either a red C, which is a confirmed, or a smaller pending. So that's how we can tell who has truly got the order to go. So it's a mixed bag about PAs and nurse practitioners. There's times that they do the discharge, sure, or they put the order in. So it just really depends on the type of patient. We do not use a lot of nurse practitioners or PAs in the hospital. They're just on a few services.
Great, thank you. Our next question comes from Justin, who asks, do you have a hospitalist physician model or a community physician model?
We have a hospitalist model. We do, however, have independent community physicians. However, they only are probably 5% of our physicians. So the majority is hospitalist or specialist.
Great. Our next question comes from Ferris, who says, hospitalist administrator here. How did you solicit hospitalist buy-in for identification of 2 VIDAs each day and follow through the next morning for discharge orders?
Yeah, it could be a challenge. And for us, we did a lot of one-on-ones, presenting at their meetings, letting them know that, we understand they have their prioritization, who they're going to see first, second, third. And all we asked was that as long as you can get the order in before 9 o'clock, 9:30. Now we do struggle a little bit with the private hospitalists. Sometimes they do come in later in the day. So we do ask that they can put the order in at night with the pending. The nurses will call in the morning of. But I think of just information, communicate. The greater, once they do have a couple of VIDAs, their workload is now, instead of having 12, 14 patients, they just discharge 3 or 4 of them. So now they can kind of get their bearings going, and their caseload has just been reduced. So a little bit of everything.
The head of our hospitalist group is on our steering. So it really helped having him be part of our steering group. And that was intentionally so that, and then we also, if he can't make it, a one or two, what we call physician advisors will attend. So they're aligned, their group is aligned along with the hospital goals, so that they can help lead their different physician partners. But we did a lot of cheerleading for the physicians, to be honest. I mean, that's where they had physician champions, they got certificates, we included them in the celebrations, and they really got into it. Occasionally, we would actually have a physician write an order, do not make my patient a VIDA. And we met with that physician and would explain to them, that's not an option. You know, we're all in on this. This is a hospital-wide goal to change our patient flow. And we expect that you're part of that. So they stopped doing that.
Yeah, I haven't got those in a long time.
Right.
Great. Our next question comes from Lisa, who says, can you briefly speak to some of the Kaizen events done?
Yeah, we did 3 Kaizens on the 3 different goals. So there was a group that was the emergency department leaders and this nursing supervisors and bed control. They took on really unpacking the ready to move. And what we found out was, which was leading to batching. And then it was leading to not really assigning and a lot of phone calls. And there was just a lot of things dragging that down. But what we found out was that the leads were all doing the ready to move, not the nurses. The patients weren't ready to move. There was a workup that still needed to be done. The supervisors did not believe that the patient was ready to move, so they would take their time in assigning the patient or having to double check. Then they would all batch at the end of the shift or at certain periods of time, and we were only allowing a clean bed to be assigned. So as part of that work, we changed that to the nurses were the only ones that said ready to move. And we do a daily report to the emergency department so they can see who is actually activating that and what is the time frame between their ready to move to being assigned, so that they could see how well they're doing with that. And we did the same thing for the supervisors so that they knew their metrics of how fast they're assigning. We also started to assign dirty beds, and that was something we did not do here. It was a little clumsy and people wanted to stop because we had some mistakes in the beginning. But what that gained us was the ability to call report while the bed's being cleaned. And then once it turned green, which meant that it was clean, then they could transport the patient upstairs. So that really helped us pick up minutes, and minutes add up. So that was on that particular one. All the leaders had to put their information on an A3. They presented at every steering meeting. They presented at our large management group. I mean, we really had a very high level of everybody's looking at this. We're all talking about it and a lot of accountability. For the EVS piece, the same thing. We had the EVS director along with a lot of operational leaders to help him with that, and the supervisors to taking a look at the EVS piece and how to improve their response time to the units, and getting those rooms cleaned. Really made leaps on that. They were getting there, you know, like 20% of the time within that 30 minutes. And now they're more like 60% of the time. So that really helped. And that kind of came down to communication, geography of assignment, and not, we were making every bed a stack clean, and every bed is a stack clean, then no bed is a stack clean. So there was things that we learned through each of them that really made a difference. The VIDA Kaizen was complicated and there was many iterations of it. The SOP changed quite a bit. We really embraced the true PDCA cycle. I had a cascading through each of these goals, and you didn't get a prize or a great job, you almost made it, because I don't do that. You either hit your goal or you didn't hit your goal. So if you did, we had, you know, burrito parties, ice cream, you know, we celebrated, we did lots of cake, cookies, we did lots of things and made it very special for each of those that hit their goals.
Great. Our next question comes from Frank, who says, congratulations on the success of your VIDA initiative. Can you share how you incorporated teletracking workflows and processes? For example, using a view of pending and confirmed discharges during huddles, etc.
Daniel, do you want to talk about that?
Yeah, so
our morning huddle that we do is good.
Yeah, well, the current process around the teletracking is once nursing kind of owns the pending discharges based on the medical record, you know, physician saying plan for discharge, some of the collaboration. Once then they can make the patient pending. And then that's kind of where they decide to make the patient a VIDA. And then what they'll do is send out a text to the care team. And part of that text, the hospitalist or the physician is on that text. And then so that they know, and then what they would do is come in and write the order. And once the orders comes through, then it's considered a confirmed discharge. So that's kind of how we use the teletracking. We do have a lot of dashboards. Other than that, we have an administrative dashboard, which shows the number of VIDAs that have been selected for that day. And then we can see that on a global view. I hope I answered the question.
We did work with our teletracking engineers and our in-hospital engineers to make sure the attributes all would feed into teletracking from our charting and to make sure the connection was there, just like having the VIDA icon. We also use teletracking, that view, in our morning huddle with the supervisor and the leaders we do in the morning. And we basically call out how many VIDAs are there on the board. And we really expect that night shift is putting in those VIDAs, or the VIDAs are there from the day before. People put in anywhere from, 1 to 4 VIDAs. So it could be, any different amount. And one mistake we made is we were really trying to do VIDAs just during the week, and we quickly changed that to 7 days a week that we had VIDAs.
Great. I think we have time for one more. Susan asks, how do you use text messaging to the team to identify the VIDA?
So our texting platform is called Mobile Heartbeat. Some of you may have heard of it. And so what that is just our mobile communications device has capability of phone calls and text messaging. And you can have a care team assigned within the platform where you send one text out and it will go to the hospitalist, the case manager, the primary nurse, and the social worker and even PT. So everybody gets the same message. That's how we use the communication piece.
Everybody is expected to assign themselves to their patients on their mobile heartbeat when they log in at the beginning of their shift. So based on them assigning themselves to that patient, then they get all the different alerts and information about their patient. And when we are talking about a patient, you can select the patient so that it populates into that text.
Great. Shanna, Daniel, thank you so much. We appreciate the time. We were getting a lot of kudos. Awesome presentation. Have to jump off for capacity meeting. Enjoyed this. Looking forward to reviewing the slide deck.
Thank you all. We really appreciate telling you about our story, and we're certainly available to answer any questions or to be of any help. We understand that it really takes a village, and this is not easy work, but it's really meaningful and it makes a difference.
It's our pleasure. Thank you for having us.
John and Daniel, thank you very much for sharing the journey and your best practices. I think they're very receptive folks to taking some questions through their emails. So if your question was not answered, please reach out to them. And if you'd like to explore how teletracking can help you achieve some similar objectives and outcomes, please don't hesitate to contact your teletracking contact. And if you don't have one, you can send something into marketing-info@teletracking.com. Shauna and Daniel, thank you so much. Appreciate it. Be safe, everyone.
Thank you.
Bye-bye.
Bye.
Thank you to all of our attendees. And all of our distinguished speakers, please visit our website, brinetwork.com, to see our upcoming events. Have a wonderful rest of your day.